more than 70% of the people go on to this everything through their mobile device. That's how the world is today. Well, I want to, get started early because we got the dynamic duo here who turns out, I'll introduce in a few minutes. I want to just welcome our members. Happy New Year to everyone. This is our first meeting of 2023. So welcome back. Wish everybody a happy, healthy, exciting 2023. We have some programs coming up that I have in front of you. I do have everybody as a go-to meeting, by the way, which means that at some point, if you want to show your face, feel free. If you're eating dinner and you don't want to see us see what you're eating, feel free to shut your camera off. Please mute yourself if you have dogs, cats, young children running around. But feel free later on at the end of the program to open your mic and let's chat and ask questions. January 13th is our first happy hour of this year, virtual at 6 p.m. Eastern. Please, I'd like everybody to bring their favorite beverage or their favorite mixture cocktail or mocktail. January 21st is 11 a.m. Business of Dentistry continues with Gennady Sirota about practice profitability. And then one of our members, Jeffrey Ganellis, on January 25th. So we have a great lineup. For those of you who are not members yet, please support specialty dentistry. So that for those of you who have not been a member, we just hit our 3-year mark in iADS. And we have about 350 dental specialist members. So pretty excited that in the last 3 years, we've grown significantly. And really our basis is to support all dental specialties under one umbrella and let the world know what our specialties do and represent. So if you're a believer in that, please send me a text and join and support our dental specialties. So I don't want to take up any more time. I want to welcome our 2 members who have been supporting iADS for years, and actually people I've gotten to know personally. And I just found out a few minutes ago that Anna Giglio was a neighbor of mine growing up since like high school. We lived 2 blocks away, so it's a very, very small world. But Graz and Anna, I've picked their brains on a lot of dental topics and actually spoke to them a lot about their practice as Anna's a periodontist and very involved in our organization, and Graz is a prosthodontist, both diplomats, both board certified, both great people, and like me, parents of 3 boys, so we got to give them a lot of credit. It's not easy. So the 2 of them practiced together in New York City. You've seen Graz show his years ago, one of our first programs he presented his digital dentistry. And that's one of the things I call him about when I need digital advice. But they have a very unique practice. They're independent and together, I'm sure they'll share some of their thoughts on that. I think it's a great duo, and I don't want to take up any more of your time. Let's welcome Anna and Graz Giglio.
You'll see if we can get. Can everybody see this? Good.
All right, perfect. So Alan, thanks very much for the kind introduction, or I should call you neighbor. And we really appreciate the opportunity to speak with everyone tonight. And really, it's a pleasure to share our approach to achieving optimal implant aesthetics and how our experience together over the past 30 years has influenced our philosophy. For all of us, treatment modalities continue to evolve. From the time of our residencies, we now know that implants don't necessarily last forever. You can x-ray the implant at the time of placement, healing times have changed, and so forth. Just a little housekeeping on my end. I am currently an officer for the American Academy of Periodontology, and the opinions expressed are my own, and they don't necessarily reflect the opinions of the Academy. So thank you for that. So we believe in a team approach, and we integrate the surgical, the restorative, and technology all under one roof. And where these three entities intersect is where we collaborate, we plan, and we coordinate patient treatment.
This is our team that we work with on a daily basis, and they're all professionals. Many of these individuals have been with us for over 20 years, and we give them credit for a lot of our presentations because they get our presentations ready. They help us with the radiographs, the photos. They do all the lab work for us. But we want to stress that what we do in our practice is we work with other specialists and with GPs all the time. So you can achieve the same results as we achieve with other practitioners. And it's not just that we're limited just to our practice. We work with a whole host of people, sometimes even outside the state. So here's a video of the way we operate in our office. We're in Midtown Manhattan. This is our staff in our office. It's about 25 years old. So we're fully digital. We're using CBCT. We have a full lab. We have technicians that do analog and digital. We have scanners in the back. We have milling machines, design computers, printers. And this is one of our hygienists scanning. It's another one, hygienist. And we collaborate all the time. We do some guidance. And here are staff members. They're scanning a full arch. And we've also incorporated smile design in our office.
Okay, so our goal is to provide improved patient care and comfort by optimizing aesthetics, respecting the peri-implant complex, and treatment planning and coordinating with the team to reduce the number of visits that's necessary for patients.
So I'm going to just go through a roadmap of what we're going to cover tonight. Our philosophy, surgical and restorative parameters to achieve really good results, treatment planning and options, treatment coordination, and then we're going to talk a little bit about digital workflow and the digital workflow that we use. And it's pretty much universal. So let's go into the philosophy. We like to use single units here, screw retain restorations. We're talking about implants only here. We go right to the fixture with a monolithic restoration, either lithium disilicate or zirconia. Sometimes we put a little bit of porcelain on it, and you can see a screw access opening. When we do multiple units, just a quadrant, we're using this type of restoration where it goes over multi-units. And then for full arches, we're doing the same thing. Basically, it's the same process. This is all digital. And we go with a complete arch restoration using zirconia. Sometimes we'll use some type of frame. And then this is the restoration that we're able to achieve on pretty much a routine basis. But one thing that as specialists we have to be aware of is the transition line. And we believe in adding bone, and a lot of people just take away that bone and reduce the bone for that transition line. We tend not to do that. We'll work with that bone wherever it is. So if one wants to customize posterior units, we could also do this. We could use some zirconia abutments and then an overlay of some sort, but we like to place a hole in it so that it's retrievable. So we can call this a screwmentable. And these are the types of restorations. We don't do many of these, but we do it sometimes in the anterior region. So that gives us the flexibility of being retrievable and also customizing our abutments. And this is the screw access opening. So we have retrievability options in this case.
So let's now discuss how in the anterior, how we restore in the anterior region. So this is a patient who came to us in the early 2000s. And since that time, we've made treatment modifications in the anterior region to enhance aesthetic outcomes by embracing the philosophy of placing the definitive abutment at the time of implant placement, whenever possible. And this assists us in shaping the gingival tissues. It helps to support the papilla. And most importantly, restoratively, we are shifting the prosthesis margin to the height of tissue rather than working far subgingivally. So we have adopted the one abutment, one-time approach, as there is evidence in the literature that repeated connections and reconnections can increase the chances of marginal bone loss. So while there are many factors that involved in immediate loading, primary stability really is the key, as discussed in the literature by Gapsky. So you have to have primary stability, and without it, do not attempt to load the implant with a provisional. So, I'm sorry about that.
Go back. There we go. Yep, there we go. We're
Here
good.
we go. I apologize for that. So in Gatsby's review, he stated that a minimum insertion torque of 35 Newton centimeters is what really is going to signify primary stability. In more recent literature, we see that they've shown that between 25 to 35 Newton centimeters is acceptable, while Norton states that it can be as low as 20 Newton centimeters. So a few years into starting the one abutment one time, we met with Linda, and this was one of the first cases that we treated immediately, placing implants in a provisional in the same day. Now, she is a healthy 65-year-old who didn't want to prep the adjacent teeth. Her occlusion really was not allowing for us to use a resin bonded retainer, and she was also refusing to wear a removable appliance. And the only other caveat is she was the wife of an oral surgeon that we were very friendly with and who referred to us. So we wanted to make sure that Linda was happy, and I'm sure many of you out there can understand that. So if you can see, what happened is that she presented with resorption on the central, and she had decay and a fracture on the lateral. And so following, we decided we're going to extract the teeth. We placed immediate implants. I used an allograft in the space into the extraction sockets, and then zirconia abutments were screwed onto the implants. And here you see a facial view of that. And this is the patient as she was going to leave the office that day. So she's very happy. She has a fixed provisional. It was a minor invasive procedure. And you can see here the patient 2 weeks later. And yes, there is blunting of the papilla in the surgical area, but we're fortunate because it is symmetrical with the contralateral side, and the papilla length really is reflective of the existing osseous height in the area.
So protocol was about 6 months then to let this heal, and we take off these provisionals, and this is what we get. And as you can see here, we are a little bit subgingival on interproximals. Now, today, what we do is we raised up and scalloped that tissue, but it worked out fine. This is the occlusal view. Maybe we can improve on that tissue a little bit, but this was our first case, and doing 2 implants right next to each other is quite difficult. This is the result that we achieved at the time. This was over 20 years ago. And then this is the occlusal view. We didn't do the screw retain. We did cementable at the time, and we could possibly just put an access opening if we wanted to there. And we've learned a lot from this. This is still functioning. The patient's happy. And we've learned a lot, and we'll show you what we learned. These are the radiographs. These are the old Branamark. I think a lot of these were smooth collars, and it's reminiscent of the times, but these worked out fine. And so we also adopted the theory or the concept of one surgery, one abutment, one time, which affords us a lot of flexibility, because now we are able to put a provisional on and do it all in one surgery, and the patients are very happy, and they walk out of the office with a provisional, and then we just come back and treat the implants just like natural teeth. So the reason why we do this is it's basically 3 advantages. We don't like working subgingival in this environment. We'd rather put an abutment like so. And so we're not taking this on and off. Disconnect, reconnect issue is solved. We're working supergingival. Say we have to stain and glaze these teeth because it's central, we got to match it. It's very easy to do when you can take it on and off instead of having to screw it on, take it off. Staining is a pain. And now we've also achieved retrievability by being able to make a hole on the lingual surface And we use angulated screw channel here, and we're able to take these on and off at will if necessary. And if you want to cement it outside the mouth, you're able to.
So we'd like to share with you what we have learned together in the past 30 years through trial and error. And the techniques that we're going to share this evening can be incorporated, as Graz said earlier, into your daily toolbox. You don't have to practice with a lab, a surgeon, a restorative dentist all in one place. The advances in digital technologies such as the CBCT and intraoral scanning really facilitate communication between the different parties involved in treatment.
So I just want to summarize, everybody should be aware of this. This is a consensus from 2017. A group of leaders in the field of implant dentistry got together at NYU, and what they did was they broke up into 4 groups, and they came up with a consensus for single teeth. But this really falls, it falls under the category of every implant. You should be able to use the same theories. And so let me just summarize this with you. Abutments, disconnect, reconnect, we keep mentioning it. That is one of the concepts that we don't want to invade and go into that tissue and lose tissue, and we want to avoid that. So reduce the number of reconnections. The next thing they came up with, and these articles are well documented in the 2020 International Journal of Peri and Restorative Dentistry. Then they talk about implant necks, and they're all for platform switching, which many of us use. Then Steve Chu wrote an article on the profile and a concave subgingival contour. That's the theory that we work by these days. And then finally, Zaraz came up with probably the most monumental of all of these articles. They summarize that in high aesthetic areas, you want to use a ceramic abutment or ceramics. Low aesthetic areas, you want to use a metallic abutment. And then we want to be generous with our soft tissue grafting to get better aesthetics. And then what we'll talk about is the tie-base hybrid. That is a tie-base cemented to a ceramic abutment in order to get the strongest and most aesthetic restoration possible in the anterior region. And I believe that this falls true for everything that we do.
So let's talk about immediate placement and immediate load. Alonzo was referred to us by one of the orthodontists that we work with routinely, who felt that the right lateral incisor that had fractured was non-restorable. So if you take a look at the radiograph, you can somewhat make out the image of where the fracture occurred. And if you follow that green dotted line, that's the buccal subgingival point of fracture. And on your far right, you'll see sort of an occlusal view, and you cannot clinically see how far that fracture does go. So we discussed with the patient that there was a possibility to do endodontics, forced eruption, clinical crown lengthening, and a post and core. But the patient was not interested in going through orthodontics. And frankly, I think Graz and I were both concerned because of the apical extent of the fracture about how good this would be for as a long-term abutment. So bringing together biology, mechanical innovations, and planning, we could provide a predictable treatment for this young man. So we digitally planned the case, and here you see the proposed angle for the implant. We also then had the lab fabricate a surgical guide, as well as a zirconia custom abutment that was designed for delivery at the time of surgery. In addition, we then fabricated a provisional with wings in the event that we could not be able to load the implant at the time of placement. So using the surgical guide, we were able to place the implant in the desired position. I grafted, I secured the abutment, then Graz cemented a provisional crown onto there. And this is the patient 2 weeks later when he came in. Now he's thrilled. It's a straightforward, simple procedure. Post-op discomfort is minimal. And technology really simplified the visit for us by providing a service to this patient that resulted in this digital transformation. And going forward, once the healing time is done, you can treat this like you would a conventional fixed case.
And you can see here how we scallop the tissue, and it's supporting the papillae. And we made some modifications. Digital does help us, so we can plan all of it. This is pretty much fabricated before. So it has changed since the time we treated Linda 20-something years ago, where I didn't support the tissue in between with the scalloping, but these are custom abutments now. Here is the crown going on, and then we cement it. And if you'd like, you can make a access opening on the lingual, because it is an angulated screw channel and the access is on the lingual surface. Here's the radiograph and of the integrated implant. And this is the patient after having his teeth. This is before and then after bleaching. And I think we got a very nice result, and we maintain the gingival papillae. And he's very happy with this result, and I think it'll serve him very well.
So let's now discuss surgical and restorative parameters. So the peri-implant complex is defined as the hard and soft tissues that surround an implant. And with the increasing incidences of peri-implantitis, it is essential to understand biology and the hard and soft tissues that create a stable environment. So if you keep in mind that implants, that with the natural tooth and with implants, you have both a sulcular epithelium and a junctional epithelium. On the tooth side, you have supracrestal fibers that are going to attach the cementum of the tooth, providing an additional protection. But there is no PDL, and there are no supracrestal fibers that attach to an implant. So on the implant side, the only line of defense that you really have is that soft tissue seal around the implant collar or abutments. So when we talk about surgical parameters, let's talk about hard tissue. Esposito talked about how you want to have about a minimum of 1.5 millimeters between a natural tooth and an implant. Then Tarnow spoke about spacing between two implants, and you want to maintain a minimum distance of 3 millimeters. And of course, Grunder discussed implant thickness on the buccal for long-term stability, and he would like a minimum of 2 millimeters. He would really prefer 4, but so would most of us, and I don't know how many of us actually ever achieve that goal. In addition, now let's talk about the soft tissue. So we discuss the horizontal soft tissue thickness of minimum of 2 to 3 millimeters. And then the vertical soft tissue, you want to have at least 2 millimeters of tissue thickness. And in Grunder's classic article, he discusses the three-dimensional positioning of the implant. And so vertically, you want to be 3 to 4 millimeters apical to the gingival margin to allow for development of an appropriate emergence profile. And from a horizontal perspective, you want your implant to be placed sufficiently palatal so that you're going to allow for that 2 millimeters of bone thickness that you want for stability.
And elaborating on that palatal placement, we want to angle it slightly so that the access opening is directed slightly to the palatal instead of the incisal edge. And you can see the access opening in this diagram. And then also what Grunder talked about is to place the emergence profile, the buccal emergence profile at the gingival level, about 1.5 to 2 millimeters of the tooth being replaced. So as you can see here, you want to be about 1.5 to 2 millimeters palatal to that line where your emergence profile starts at the gingival margin. And this is important, so it gives you enough room to be able to develop that emergence profile and develop a good looking tooth.
So when considering implant size, I know that in my residency at the time when I did my initial training, it was always bigger was better, and it's not necessarily the case. And narrower implants do afford us more space for greater thickness of volume, both of the hard and soft tissues, which is something that is really crucial for long-term stability of the implant. And I think that's something that all of us in our practices can speak to.
So when we look at the restorative parameters, and I'm just going to lay out like 7 or 8 of these now, the first one that you should consider is the screw access angle. And that's because we have to make this retrievable somehow. Okay, so we don't want it coming out the buccal. And we are placing this implant, as we talked about the position surgically, slightly angulated, right, probably 12 to 17 degrees. That's just because of the way the bone lays. You don't want to be coming out of the buccal on the apical portion of the implant. And so one thing is, this is the tie base hybrid. If I didn't show you before, this is it right now. You have a tie base with some ceramic on top of it. You want an access on the lingual. So we want to have an angulated screw. We use an angulated screw channel all the time, pretty much on these situations, and also posteriorly, not just anteriorly. And what is the angulated screw? It is so that a ball-ended screwdriver can go in there and tighten this screw at 35 Newton centimeters. So when we talk about the angle or the screw axis angle, we're talking about the angle of the implant as it relates to the screwdriver. And so we want to keep that under 25 because that's our limit. So we can't put it more of an angle. So you have to keep that in mind when placing the implant. So what I'd like to show you is this angulated screw concept where you have a tie base, and you can see it there blown up. That's the tie base that gets cemented onto a piece of ceramic, usually zirconia and then porcelain on that. Or you can do it as a two-piece. It's designed virtually in the computer, as you can see right here. It's all done virtually. You have to scan the patient and you have to have a CBCT. And then what I'd like to show you is the real thing there, the abutment, the screw, the angulated screw, the screwdriver with a rounded head, and the implant, and how they relate to one another. And this is a great concept. In 2014, when it first came out, it wasn't so good because we couldn't tighten these. But now the companies have stepped up and they're much better. This is it right here. Now let's see. What I'd also like to show you is, and a lot of companies are now starting to come out with a prosthetic screw, the small screw that's angulated, and that affords us a lot of conveniences now. Why? Because we can design this virtually beforehand. You can have an angulated screw, the prosthetic screw, and you can put a straight abutment like I did here, even though the implants are angled. And so you don't have that unsightly collar on the buccal and have to use angulated abutments. In this case, we can get this type of result, even though the implants are slightly angled to the buccal. Now I'd like to go through some of the other things. I think we've hit this multiple times, but I just want to enumerate it. The abutment, disconnect, reconnect. I'd rather work at this level than working at the implant level. I'd rather work supragingival. Then we have to talk about the prosthetic contours, and we control that as the restorative dentist. So we need to know where we should put our contact point. And Cochette showed that you have to put it at about 5 millimeters. This is the contact point between a natural tooth and an implant. And you want to have it 5 millimeters from the crest of the bone, and that'll fill in 100%. On the other hand, Tarnow showed that in between two implants, the mean papilla height is going to be 3.4 millimeters. So your contact point has to be a little bit lower. You're not going to get that 3.5 every time because that's only the mean. And so you have to plan for that. Otherwise, you're going to have an unsightly triangular space between the papillae and the contact point. So a way to get around this is Salama talked about how we can use an ovate pontic, and we use the ovate pontics here. And to get this type of result, you're going to get a better papillae between these pontics, or even a single pontic, than you would between two implants. In talking about the restorative contours, again, Stephen Chu showed that one of our colleagues here in the city, that you have to have a subgingival contour that's concave. And when you get the restorations back, you could rubber wheel this and make it concave, because now the tissue is going to fill in and attach to that zirconia abutment. When we talk about the restorative materials, we have 4 restorative materials that the literature is clear on. They allow for binding of the epithelium to these materials. You have titanium, zirconia, alumina, and lithium disilicate. And these are the ones that are accepted subgingivally. When you start putting porcelain underneath the tissue, that's not healthy. And the other thing that we need to consider is the aesthetics and the tissue thickness. Anna talked about 2 to 3 millimeters in all these different directions. But in order to mask out that titanium, if you're not using zirconia, then you need to have 2 to 3 millimeters. And in most studies, they show that you need at least 2 millimeters, if not 3. It's pretty clear. And everything that we do, we were showing you is evidence-based. We're showing you the articles, and we've reviewed them over and over again over the past 20 or so years. Now, we want to avoid this where we have porcelain. Anna put these implants in, and one of our restorative dentists sent us back, during just basically we alternate cleanings, and we found that porcelain to the implant level. This is what the patient came in with. And when we had to clean this off and we had to polish off the porcelain. So if you have any porcelain subgingival, get rid of it because it's not binding or allowing the binding of the soft tissues or the epithelium. Only zirconia and titanium in most of these cases works. So now let's look at whether we screw or cement retain our restorations. That has to be thought about before, because you have to let the surgeon know where to place the implants, or you have to agree on it, because if you have these unusual angles and you have to use angulated abutments, it may be unsightly. You may show the margin. So a nice article by Saylor showed here a systematic review of how you can use either. It's pretty much accepted. I know that we favor screw retained restorations, but either one can be used. In Europe, there's a lot of people using cement retained. And what they show is that in the screw retained restorations, you have more mechanical failures and complications. And in the cement retained ones, you have more biologic complications. That's what it's divided up into. And because of the cement going into the sulcus and causing an implant failure or peri-implantitis. And then finally, as a prosthodontist, I have to mention occlusion, I'm sorry. But anyway, we believe in a mutually protected occlusion on implants. So we want to load these implants straight up and down, axially. And so we want to protect the anterior teeth from getting lateral forces. So the posterior teeth are in occlusion. The anterior teeth are lightly in occlusion. That's mutually protected. And in excursions, the anterior teeth protect the posterior teeth, so you don't put any lateral forces on the posterior teeth. Then Grishis here's talked about how the collar surface is very important. A lot of companies are now coming out with either anodized or machine polished collars, and this is important. And the literature clearly shows Boozer, Cochran, Dennis Tarnow talk about this, that we want a hybrid design. And so what we would like is something that is bone friendly and then roughened at the apical portion of the implant, and then the top of the implant, the collar should be smooth. And these are the companies are coming out with it. And so you can choose what you'd like, but having a roughened surface all the way at the top is a problem, especially with a patient that has periodontal disease, or if you're trying to avoid peri-implantitis.
So with regards to the abutment implant connection, with the platform switch system, it allows us to move the microgap more axially. Therefore, the exotoxins are further away from the bone. In addition, platform switching will shift the mechanical stress from the periphery of the implant internally towards the long axis. And what this does is it reduces the potential microgap that occurs during functional micro movement. So here we're just going to quickly summarize what we discussed. As far as surgical, we know that the implant spacing is important, how much room between implants and teeth, between implants and each other. There are minimums for both the volume of bone and soft tissue for long-term stability. And when actually placing the implant, you want to keep in mind the vertical and horizontal positioning of that implant, and also the size of the implant to pick something that is going to allow for sufficient thickness of bone, especially buccally, for long-term stability.
So in terms of restorative, there are a whole host of parameters that enumerated here. And your contours are important. Your disconnect reconnect issue, you have to have zirconia. You should have zirconia. Anytime you have titanium in the anterior region, you're going to get some graying of that soft tissue, or you're going to get a halo around the tooth. Know your materials. You can't put porcelain like a lot of technicians do subgingivally. We favor screw retention and understand occlusion. That's why some of these implants fail too. You're overloading them. And then finally, understand the collar, the features in the collar of implants. You want to use a hybrid design most of the time. Avoid roughened collars all the way to the top. And we want to use platform switching for mechanical reasons and also moving the microgap internally.
So let's review some of the patients that we've treated in our practice together. So this is Hyun, who is an 80-year-old gentleman. He's healthy. He's wearing a removable partial denture on the mandibular arch. There are failing teeth as well as failing implants, and the maxilla has a fixed partial denture with some failing teeth as well. So here are his radiographs, and the plan was to extract the maxillary molars, which were hopeless. There was extensive decay there. They were deemed non-restorable. And in the mandible, we were going to we had to sacrifice the 2 remaining teeth for the treatment plan. And the implants that you see there, both of them had complete loss of buccal plate. There was no attachment, there was separation, so those implants were planned for removal.
So we're using a digital workflow here. We were able to take the CBCT, marry it to the intraoral scan. That's basically the way we do everything in our office when it comes to these complicated cases. Even in single teeth, we do this, but it just makes it easier to plan everything. And so if you can look at this carefully, we've planned where we're going to place the implants and also come up with a wax up. So it is restoratively driven in most of these cases, but to tell you the truth, it's really the surgeon determines where the implants are going to go. Yeah, I can tell Anna where to put the implants, but she's going to say, I don't have enough bone there. So I kind of have to adapt to where she's going to be able to get these implants pretty straight. And that's just the way it is. And I see when I go around the country lecturing to groups, it's usually the surgeon making the decision on where the implants are going. So now we're able to come up with a wax up. We have to do it as 2 separate files here, the maxillary and the mandibular, because you take different CBCT scans here. And so what we're doing is we're going to plan this, and we're going to mill these provisionals. And what I want to bring to your attention is these seating guides. This allows us to seat the provisional in the right vertical dimension and place it correctly, as opposed to kind of having this dangle around. You can reline it correctly and have the patient look like this after relining it. So we serially extracted the teeth in the mandible, placed implants, some temporary implants, and now we're able to get implants in the lower, 2 implants in the maxilla, and we were not able to place any implants in the premaxillary area. And that's okay, because we're going to use a fixed bridge there. Now, these are the multi-unit abutments, well-spaced, and we're going to do a full arch restoration here. So Kim is a classic article in 2019, where it's very hard to use digital dentistry here or scanning to replicate this and put it in a virtual world and make a restoration. It's not going to be accurate. So what most people do is take an impression at this level and then scan it in the lab with a lab scanner and then fabricate a zirconia abutment or restoration. Now, let me talk a little bit about photogrammetry that you might have heard of. It is a technique that's new. It's out there. Technicians come to your office. It's expensive. They take pictures of these abutments. They put little flags on it, and it is worthwhile. You pay the technician, and then they send you the restoration. The dentist kind of loses control. Now, here's the third option that just came out in 2022. These are called scan gauges. They're horizontal scan bodies. You know, usually the scan bodies are vertical. These have a lot more surface area in a horizontal plane. And so when you scan, you don't really have to move the scanner that much, because you're scanning multiple abutments here at the same time. And so they look like battleships. And what you do is you take 2 scans, one from left to right, and then you right to left. And then I would like to show you a heat map, which represents the 2 scans that I took here, or we took in our office, and they're within 20 microns. And then they go through an algorithm, which makes these even more accurate. They kind of get these in the right position. And so you're able to get a restoration that passively fits. And we can talk about this later if you want. We can do it in the question and answers session. But in the maxilla, we were able to make a full zirconia veneered restoration, 10 units, then 2 single units, as I talked about, right to the fixture level. Then we were able to make a titanium frame with zirconia cemented over it and then screw retained. And this is the anodized titanium surface that's going to stay that color. It's not plated. It's going to stay that way. It's going to stay that color. This is the preparations in the maxilla, the final restorations with the screw retention holes, and then patched up with some composite. This is the patient smiling. And then this is the intraoral frontal shot. And we just left him high and dry posteriorly because he doesn't really show it in smile. So these are the radiographs now of the completed restoration.
So this patient is very similar to the one that we demonstrated at the beginning of the presentation about that was done 20 years earlier. But by doing this digitally, it afforded us, more flexibility. The patient was comfortable. It was greater accuracy and efficiency. And we were also able to delegate a great deal of what was done to the staff. And so here you can see radiographically, some perio on the top, 2 implants to give him some molar occlusion. And as we had said before, on the lower, it's a full arch prosthesis implant supported. So when considering treatment options, as you may have guessed, immediate placement and using an immediate loaded provisional is really our preference, as exemplified from some of the cases that we've already shared. But let's discuss some treatment options when we can't immediately load and or place. So now we're going to talk about immediate placement and using a resin bonded provisional. So here we have Rob, who had a little bit too much to drink on a Friday night, and he face planted and ended up in the ER. So you can see the radiographs here, and he did quite a number. He fractured the lateral subcrestally, and he chipped off a good portion of his central incisor. So we, in this situation, let me just show you here, we decided that the tooth needed to be extracted. So it was removed. An implant was placed in a palatal position. I placed an allograft into that space. And then there was some clefting. I don't know if you recall or not from the initial photo. And I didn't feel comfortable loading it because I didn't like where the gingival margin was going to end up here for the soft tissue. So I did a subepithelial connective tissue graft to augment the soft tissue, and we submerged the implant. And then what was done is you always need to have a plan B. So the single unit provisional, gave it to the lab, they added a wire, and you see it here bonded in place to hold the pontic. So this is after the implant had healed, we did a very conservative uncovering, just a minimal crestal incision to expose the cover screw. The abutment that had been designed previously was then placed onto the implant, and the resin bonded retainer was converted back into a single unit provisional. And this is how the patient left the office that day. Now, you can see that the margin on the lateral is a little low, but too much tissue is always an easy problem to solve. And this is how the case was finalized.
Yeah, so we put a laminate on tooth number 9, implant crown on tooth number 10. And just to show you here, we were able to achieve a nice gingival zenith there. That's where it belongs. It looks natural. And then there's a frontal view here, realizing that, tooth number 9 is a laminate veneer. Tooth number 8 is just a natural tooth, and the technicians were able to match it and get exactly the same, craze lines and translucency and everything. And tooth number 10 is an implant, and we were able to get that type of tissue, but we had to manage it correctly. Now, this was done a while ago. I think it was total 17 years ago. He moved to Chicago now, but this is before, this is after he shaved for the occasion, and we bleached his teeth as well. This is a 10-year follow-up. And then after that, I've been in touch with him since. He's still, he's seeing a prosthodontist in Chicago. But this is the kind of result that you can get by just using the surgical and restorative parameters that we talk about. So what we did here is now we'd like to just review when we can't place an implant. So everything we've shown you so far is putting an implant in. Well, what about on this patient? She's an opera singer, and this is her central, and she has a vertical fracture on an endodontically treated tooth. So what we're going to do here is we're going to use a resin bonded bridge and then subsequently load it later. This is the crack line. And so then Anna was able to extract the tooth and place an implant, grafting, and I'm going to let you take over here. This is
Okay, so the provisional is in place. I had done, as Gras said, some bone grafting in the area. And you can see here from the palatal view that what we converted, again, the single unit with some wire, bonded it in place, and it's relieved so that it's going to allow for some tissue growth. We certainly want to leave some room there, preferably about at least 2 millimeters for it to fill in. And so here she is approximately, I would say 3-4 months later, and an uncovering was done. This is the abutment that was connected at the time. And Gras was not happy with the abutment. So later on, he decided to switch it out because he felt that it was under contoured and wasn't going to give enough soft tissue support.
And this is what it looks like. It's just a better abutment now here, but still we're having from the facial surface. We can see that we didn't have angulated screw channel at the time. And then we were able to do a cementable here. That's the way we planned it because of the angulation of the implant. And then you can get a result like this, treating the soft tissues correctly with that zirconia abutment and a provisional. And this is the final restoration and the radiograph. This is the patient down the line. Her name is Lavina, and she looks great years later. This is approximately 10 years later. She's still looking good. And look, maybe a little bit of recession there, but this is the type, and it holds up over time because we didn't violate any of the parameters that we talk about. So now we're going to talk a little bit about treatment coordination. And what we like is pre-surgical decoronation. I don't know if you know what that is. It's just cutting off the coronal portion of the tooth, slightly subgingival. And I usually do that and reline a provisional. And so we'd like to take you through a case that we just worked on together recently. We've done this for 30 years together.
So here we have Leo, and he's a 74-year-old African-American male. He has a history of hypertension and high cholesterol. And his chief complaint was the mobility of the maxillary right central incisor, along with generalized gingival discomfort. And I can tell you that if he sneezed too hard, that central was going to fall out. So radiographically, you can appreciate the advanced bone loss that he had in both anterior sextants. And just keep in mind, if you pay attention to the current bone level, also between number 10 and 11, it's pretty significant there. And yes, that is a double cantilever on the posterior left sextant. I thought initially they were roots there, but it's not. So clinically, he has localized, 5 to 12 millimeter probing depths. There's bleeding on probing. You can see the suppuration that's present. He has a tongue thrust habit. All the incisors are mobile. They've all flared buccally. He would be a stage 4 periodontitis localized, and he's a grade B.
So in this case, we use that, decoronation technique where the hopeless teeth are decoronated to the gingival margin, sometimes a little bit below, depending on, the size of the roots. And then I'm going to reline my provisional. So that affords us not to have to do any relining or any manipulation with the provisional. The lab is trimming this and glazing it. And again, you can do this. You just have to have a restorative dentist and a periodontist or surgeon in the same location to be able to do this. You could have the restorative dentist trimming this while the surgeon's putting in implants or grafting. So when the patient walked out, this is how they walked out of our office. Anna did some grafting. She didn't put any implants in, and then everything sutured up. And the patient's very happy because now he walks out with teeth that look better than when he came in with.
So now here we are, about 4 or 5 months later. The hopeless teeth had been extracted, and GBR had been done in combination with an allograft, biologics, a non-resorbable membrane that was tacked in place, and as well as some GTR around tooth number 10. So at this visit, I placed implants in sites 4, 5, 7, and 8. And the fixed partial denture that he had come in with was just re-cemented at the end of the surgery to continue being used as a provisional.
So now we have the virtual file here of just a scan with the scan bodies in, right? And we're going to capture the natural teeth that are prepped and the scan bodies for the implants all in the same file, which is really neat here. And then let the technicians do their thing. Then now here, this is the wax up from the initial, what we came up with from the beginning, pretty much just duplicating it. These are the final restorations, or you can mimic the provisionals. And then these are the printed casts are printed on a 3D model printer. And then we're made zirconia abutments on the anteriors, and posteriorly we use just screw retained restorations. And let me just show you here. These are all the restorations. So starting out with a cantilever bridge with screw retention, with angulated screw channel on the posterior units, they're 4 and 5. And then we've got 14 with a single unit screw retained restoration. We even did a laminate veneer on tooth number 12. There was no need to put a crown on it. So it's a combination of many different types of restorations, and we're trying to be conservative here. And so this is the occlusal view with the angulated screw channel. We fill this in with some PTFE. And then we're going, what I want to show you here, and this is kind of like your little trick for the day. We put little flags in there of just an instrument tape to indicate or specify which screwdriver we use. So our orange is the angulated screw for this particular implant system. And so that we know in terms of retrievability, what screwdriver to use. And what we're going to do here, it's another little trick, is to use clear composite so you can see right through it. And then we cemented the anterior units on all at the same time. So we're able to match natural teeth with the implants. And in terms of the aesthetics, you're going to get teeth to match. And then posteriorly, it's screw retained. And this is, with the way he started, and Anna's going to finish this up.
Yeah, so here you see the before and sort of the after just for the maxilla. The mandible is currently still being treated, but you can see that in the maxillary arch, such a huge improvement with just the tissue response that we have for him. And he's of course very, very happy with the improvement in the smile, with the function that he has. And from a health perspective, I mean, it's such a healthier environment. So if you look at the before and after radiographs, we were able to get a very nice result as far as bone regeneration in the sites where the implants were placed. And also I had pointed out the 10-11 area. You can see there that he responded well to GTR in that site. And so now he has molar occlusion as well as stable anterior teeth. As far as the mandible, it's being treated with periodontal therapy, took out 2 hopeless teeth, and we're placing 2 implants in the mandibular left where he had that double cantilever. But other than that, it's just going to be conventional fixed prosthodontics. So another tool available to us is orthodontic therapy. So here we have a 26-year-old woman who presented with external resorption on tooth number 8. So you can see that the defect extends subcrestally. And so how do we determine how to predictably manage this so that we can place an implant, hopefully at the time of extraction? And so we elected to force erupt the tooth to coronally move the bony housing to allow for elimination of the defect that you saw there on the distal of the central. And so the movement and the stabilization took approximately 8 months. And of course, it resulted in soft tissue migration as well. And obviously, during the course of movement, we had to keep equilibrating the provisional. So even after the forced eruption, you can see that there was still a significant defect present on the distal of that tooth, because resorption can continue even though attempted cleaning it out. This extends pretty far subgingivally there. So the tooth was extracted, and an implant was placed. Now, this is an older case, so this is actually an alumina abutment that was placed there. It is the precursor to zirconia. And we were able to immediately load the implant with the provisional that was out of occlusion. And here you see about 3-4 months later that really some nice tissue healing in the area. We have sculpting of the tissues. We have papilla that are being supported. And here you see the final restoration in place.
And here we have, this is her smile, and it's a nice result. This was done from slides. These are old slides. Digital photography wasn't available at the time. This was before 2004 when we went digital with photography. And these are the types of results that you can achieve. And you can see here where we put the contact points, where the gingival margin is in a way. You can't see it on a radiograph, you can see it on the overlay. And you can see where the implant, we use the old Brannies there, where you get a little bit of bone resorption around that head of the implant. And then you can see where the bone is interproximally. And this was maintained over a long period of time.
Yeah, so this is 10 years later. The soft and hard tissues are stable. The composite on tooth number 9 has worn away down a little bit, but you can see that pretty much the 2002 and the 2012 radiographs are very similar. So overall, I think it's a nice stable result.
And now we're going to talk about digital workflow. And what I just want to do is give you it's kind of like a timeline of the game changers that affected us over this period of time. In 1997, we discovered these ceramic abutments. They were alumina. They weren't as strong as zirconia. Then in 2002, we started using zirconia and immediately loading implants. We were still using the old Brennemarks. Then we were able to use these on a routine basis. And so we have a track record of thousands of these. Then we got into the peri-implant complex and the classic articles by Tarnell, Grunder, Cochran, Boozer. They all came around and they said, hey, there's a peri-implant complex. This is hard and soft tissues. This is follow these rules. We did that. Then we started getting into the angulated screw channel in 2014. And then we really solidified everything with the planning. The digital planning has changed the way that we operate today. If it wasn't for this planning, we wouldn't be able to do these cases. And so, one thing that we did miss, and I wanted to throw this in at the end, is multiple posterior units. How do we treat something like this? If you want to scan this, you could do this digitally. So up to about 4 units, and they're in a straight line. We put multi-unit abutments here. We can put some scan bodies on, scan this, and bring it into the virtual world, let the technicians do their work that they're good at. They're able to do this in zirconia. You can do this in many different materials. We happen to pick zirconia because it's strong, predictable. We then put a little bit of porcelain on the facial surface, and you can get a restoration similar to this one. So for a few units, and this is what it looks like after you obturate the openings and the screw axis openings. Now you've got abutments that are concave, subgingivally, so you're satisfying all of that in terms of contours. And now we'd like to take you to our last case, and Anna's going to pretty much take this over. Go ahead.
Thank you. So we're going to talk here about delayed placement and immediate load. So here you see Felipe. He's a 48-year-old male. He's healthy. He's unhappy with his smile, but with the assistance of digital technology, and his life and aesthetics were really transformed. So clinically, there is a discrepancy, as you can see, in the gingival margins. He's got some altered passive eruption. There is external resorption on tooth number 8, which was slated for extraction. And so his treatment plan was for an aesthetic crown lengthening, frenectomy, extraction of number 8 with possible immediate implant placement, and immediate load. Now, in addition, he was undergoing Invisalign therapy on the mandibular arch while we were treating the maxilla.
So we took the CBCT and then we married that with the intraoral scan. So we had everything planned. And you're able to do this in such a way where the software, the design software allows us to be able to plan this out, make a surgical template. I'm going to take you through the steps. I just want to really show you the steps of what we go through. And this was, some of it was serendipity, but then the technicians really figured this out. They made some leaps here. So we planned it just like any other case. But then they got into the printing and the milling, and they said, well, we can make you a guide and we can print that. That's usually printable. It's easy to go. You just send a file to the printer. It's like sending a document to the printer, a Word document to the printer. They could do it, okay? But then the interesting part was, well, we have a restorative file, and this is the CAD file, computer aided design. And we have actually two components to this. The first component is they can make a cast. So can you imagine having a cast before you actually do the work of your surgery? That's where the implant belongs. And then they milled a provisional, and they also milled the zirconia abutment, all done angulated screw channel. This can all be done through software. It's amazing. And now Anna's going to take you through the surgery here.
So this here is a flapless surgery to place the implant. Now, this ended up being a staged procedure where the tooth had been extracted, the site had been treated with guided bone regeneration. And so this right here is kind of a slam dunk and pretty straightforward and simple. The post-op for this is very comfortable for the patient. And so there is the implant is being inserted, and then
this is the zirconia abutment. What I want to show you is about 1 millimeter off here. So I tightened down the implant just a little bit more, like one turn. And we, even though we did it guided, I was able to change something. Then you tighten it down to 30 Newton centimeters. That's what the specifications call for. And then we align the provisional using the little wings. And if not, we could have used this as a resin bonded. And so then we trim this up. These are the files now for the laminate and the implant crown. We treat this just a regular tooth. It's not really an implant crown anymore, but and we have a hole on the lingual surface, so a screw access opening in case we want to take off that abutment after we cement in the crown. This is the radiograph with an overlay of what the final restoration looks like. And now take a look here. This is before, this is after the crown lengthening. We bleached his teeth as well. So it's a very nice result. It transformed his life.
So again, here you see the before and after smile, and you can see that it really is a huge transformation for him. He's super excited about the way his teeth look like now. And there is still some work planned for the future posteriorly, but he's really off to a good start, and he's completing ortho. So we're going to share just some take-home messages. For me, first and foremost, honestly, it's always keep learning and follow the science. That'll sort of really guide and help you. We talked about primary stability. That is crucial with the immediate placement, immediate load, or with immediate load. If you don't have the stability, don't try. Correct implant positioning. Okay. If you have to sacrifice position in order to place the implant, then abort. You need to augment that ridge, whether it's hard, soft tissue, and then go back later. 3 months, 6 months of time is not worth the nightmare of looking at a really hideous implant that has to be restored later on. And it's important that you have sufficient hard and soft tissues. Yes, we can always manage to sneak an implant in there, but when you have paper thin bone left on the buccal of that implant, what's going to happen? We all know that's going to unzip, and when the bone goes, the soft tissue is going to follow. So really take the time to understand the biology and create the foundation that you need for long-term stability.
We believe in the concept of one surgery, one abutment, one time, and it really has been a practice builder for us because patients, they come asking for it. They know that they can get this done, and we've done thousands of cases like this. And if you can't do it, then abort, like Anna says, and start all over again, building up the bone. We want to stress the proper design, the prosthetic design, and that's so important because if you don't get the right contours, you're not going to get that gingiva to heal correctly, and that's basically like the foundation is the gingiva and the bone, and then and it's not going to look right. And then finally, what I find is a lot of the restorative dentists and technicians don't understand what biocompatible materials are. They put porcelain subgingivally. You've got to know your materials as a restorative dentist and use biocompatible materials. What I'd like to do is share, this is basically what we did. We shared everything we do, including our staff here. This is the team that we work with, and how to optimize the aesthetics. And this is us fooling around, out around the office one day. This is our
That's a
Instagram.
typical work day.
Yeah, typical. Yeah, well, anyway, but I'll tell you that the staff has really changed the way we do things. They all take a liking to this. They feel energized. They all know how to scan pretty much anybody in the clinical setting, even the technicians. And it's a very nice symbiotic relationship that we've all established. And we wanted to share that with you and see the way that we operate over the past 30 years together. So we have our email addresses and our Instagram handle there as well. Thank you very much. Any questions?
Thank you. Thank you. First of all, there were a few excellent cases. Congrats. Beautiful. One comment, question, excellent work. Can you please clarify what you torque the abutment at the immediate implant placement? And how do you ensure there is no pressure on the entire restoration and implant as it is integrating? So
Okay, so we take it out. So I'm going to answer the last question first, is as we basically take off any excursive movements, we eliminate any occlusal load and excursive movements, just out of occlusion completely. That's the way we, right? Okay. And then in terms of the torque, our specifications for Keystone is 30 Newton centimeters. So we make sure that we can tighten it down to 30 Newton centimeters. Anna talked about 35, 25 to 35. So we have to get a stable implant and then you torque that down. Sometimes we may have to hold it with a Fuji plier, the abutment, in order to tighten it down, because you don't want to overload that implant. And we sometimes tighten it to 20, 25. This is the screw, the abutment screw. And then go back, put a note in the chart or a flag in there saying we need to tighten it to 35 or to 30, whatever the specifications are at a later time. Because if the implant's starting to spin, then you got to stop tightening it. I hope I answered that question. Oh, did we lose him?
Did we lose him?
No, we're good.
Okay.
We're good. Can you guys hear me?
Yep.
Yes.
Okay. I don't see any. I do have a question. So,
Sure.
by the way, that was great. Thank you so much. With the decoronation, do you find that, is there a certain time frame if are you doing pulpectomy or what's?
Oh, no, it's the time of surgery. I decoronate first, reline the provisional, and then Anna extracts the tooth the same session.
Same day. Okay. I missed that.
Right then and there, right? Yeah.
Okay.
We do it just before. And here's the other thing. If you're working in two different offices, what I would recommend is go to the restorative dentist first, right? Decoronate, reline the provisional, send the patient off with that provisional in the mouth, and then the surgeon cements it in later after surgery.
Great. I noticed that there was a discussion on our community site about 1 wing or 2 wing provisionals. I know you have like a backup plan, which is great. What's your feeling on 1 wing versus 2 wing for
on each side? Yeah. So we usually like to have 2 wings, and then we can always cut one off. So depending on the retention, we make those, and sometimes it's 2 wings on one side and 1 on the other. So around a canine, for example, we like to have, if you're missing a canine, we want to go 2 wings on the premolars. If it's a lateral, we'll go 1 wing. So it depends on the forces on that particular tooth.
And the occlusion, of course,
And the
the occlusion allows for the wing.
getting a lot of beautiful cases, including long-term. Thank you. Thank you. Any other questions? Feel free. Oh, I forgot to mention earlier, I did put it on the chat and I did have my email. The QR code I had an issue with for the course evaluation. So please, if you'd like to get CE certificate for tonight, I'll email you, just send me out an email that you'd like to get a course evaluation. We'll get you a CE certificate for tonight's program. We had a little QR issue with forms. Welcome to the world of Windows. Question on, what are your thoughts on PET?
PTFE on what, inside the access opening or?
Jack
what-
said, Jack Krauser, Jack, what do you mean PET? Do you mean pick or
No, PTFE? Or what? I don't know.
partial extraction therapy?
Oh,
Um,
no, we don't do that. I mean, Anna can answer that. I
I think that the one place I see that it could come in handy is when you have a tooth that's ankylosed and removal of that tooth is gonna destroy the whole plate, then I think that yes, you can keep that buccal piece of tooth structure and place the implant. But, you know, in my opinion, a lot of times these teeth are coming out because they're problematic. And frankly, it makes me nervous to keep a tooth there that I think potentially could be a nidus for infection. And I would rather remove it, place my implant more palatal, allow enough of a gap there that I'm grafting, and just create sufficient bone thickness for future support.
Great. Yeah, I think time will tell the answer on that one. I'm kind of waiting that out. We've had some of our members presenting on that technique.
it's a documented technique. It works,
Mhm.
but I've also seen the negatives too.
Well, a lot of thank yous from our group here. You guys were right on time, right on schedule. I know it's getting late. So I hope to see you guys again soon. And wait, is there anything else? No other questions? I got time for one more if there's a quick one. Otherwise, try to join me Friday night at 6 p.m. We'll have a drink together. And if not, hopefully I'll see you all soon in person. Thank you both so much.
Thank you. And thank you for all the little notes on the chat. I really appreciate everyone there sending little notes. Thank you.
Thank you, everyone. Have a great night.
Take
All
care.
right, good
Bye.
night.